Hi, thank you for joining us today. This is our webinar Wednesday. We're going to be focusing on the topic of MS incontinence, regaining control. Specifically, we're going to talk about issues related to bowel function. My name is Paige Kennan. I'm a programs manager here at Can Do, and I'll be your moderator today. I just want to take a brief moment to thank our generous sponsors for supporting this year's webinar series. Thank you. I want to introduce our speakers for today. We have nurse practitioner Jeffrey Hernandez joining us from Florida. Hi, Jeffrey, welcome.
Hi, thanks for having us.
Thanks for being here. And we also have neurologist Suma Shah out of North Carolina. Hello, Suma, how are you?
I'm well, thank you. Happy to be here.
Awesome. Well, thank you both for being here. I'm excited for all the information you're going to provide today. So I'm going to go ahead and pass it over to Suma to get us started.
Thank you, Paige. Well, we'll get started today with our learning objectives. And as Paige mentioned, we're really focusing on bowel dysfunction, which I really think is an often overlooked topic when it comes to caring for symptoms of MS. So our objectives today are to learn strategies to manage bowel dysfunction, to discover medications that can cause and help bowel symptoms, and to find ways and strategies to gain confidence and control of your bowel function. So without further ado, we'll move forward to chatting a little bit about what exactly is incontinence. And I think the simplest definition of this word in regards to our topic today is the lack of control, right? That's what incontinence is. And there's so many ways that this specific disease can contribute to causing incontinence, to providing this lack of control. Some of the causes I've listed on the left include muscle dysfunction. We know that MS, depending on where that scar hits, can cause weakness. And particularly when there's involvement in the spinal cord, there can be muscle dysfunction or something we call dyssynergia, a lack of coordination between the muscles that help the bowels move. And that starts at the very top. It can be from the upper GI tract and the stomach all the way through to where the bowels empty. Additionally, because of decreased movement for some of our patients who are living with MS, there is a constipation component that occurs, but as a result of that, there is rectal overload and overflow. What I mean by that is that because of the constipation, the stool behind it doesn't get a chance to form and solidify. And as a result, there can be this overflow, bowel incontinence, as liquid stool passes over it. Now, I know these are topics that are sometimes challenging to talk about or admit, but we're hoping today that in recognizing that this happens, you can be armed with some of these pieces of information that help recognize and then address it. And then finally, sometimes incontinence occurs in MS due to decreased rectal sensation. We mentioned that there can be muscle changes and weakness, but also as part of the nervous system, sensation can be affected. And if someone is unable to feel in their sacral area, in their groin or their bottom, that may not allow a person to get the sensation that their stools are full and they're ready to go. And by then, it's often too late to empty in a timely fashion. As I mentioned, culprits of that primarily come from a lack of clear signaling, right? That's what may happen with the scars from MS, the lesions from MS, and how they change the function of signals that come and go from the brain to the bowels to allow the stools to go on a regular fashion. But there's also other culprits, such as hydration, where in the setting of constipation, it may be happening because of lack of hydration, and then that rectal overload and overflow can occur. Similarly, as a person may have limitations in movement, the lack of it can slow down the bowels, and that too can cause similarly constipation or being placed in positions where it's challenging to quickly get up and empty when the time comes. And then finally, you'll hear a lot from us today about diet and its very central role when it comes to not only causing incontinence, but as you'll hear from Jeffrey later, to treating incontinence. And we'll chat about some specific culprits of that shortly. Next slide. So I mentioned this a little bit earlier, but I do think it's important to recognize that fecal incontinence, so stool having a lack of control of one's stool can be associated with constipation. And I often get these funny looks from my patients when I say, well, you might be running your bowels because you're constipated. And, that doesn't make sense. You feel like one thing is being stopped up and the other is going too much. But the challenge with constipation is that both our bowel and bladder really rely on stretch receptors. So how full the lining of our bowel or our bladder helps tell our brain it's time to go. But if someone remains constipated, it stretches the lining of the bowels, the rectum. And because of that, it can cause two issues. One, you can sort of get this misfired signal of the bowel saying, well, I just feel that I'm full all the time. So what difference can I tell in the brain? The second is because of this constant stretch that can happen with constipation, those muscles stay so stretched that they're not very good at contracting after that. And because of that, we talk about decreased compliance, where the muscle itself doesn't push in the same way because it stays stretched for so long. And as you've mentioned, or as I've mentioned, the two are so intricately linked that because of that, the management of fecal incontinence or involuntary bowel is very similar to that of constipation. And we'll touch on that, of course, today. Next slide. So this is where we'll spend a lot of time. And I'd love to take this moment to have you all reflect on which of these items on this very big chart here may look familiar. So I'll start at the top left. On this page, you'll see culprits for medications that are commonly prescribed agents in multiple sclerosis management. And at the very top left, I've started with muscle relaxants. This sort of makes sense, right? The muscle relaxants that we use for spasticity, things like baclofen, tizanidine, Flexeril. Some folks may use scalaxin or robaxin. All of those things, in doing their job, slow down muscle movement. And if that muscle doesn't have that compliance, that stretch and response, and if it stays slack or flaccid, then the bowels won't be able to move through in the rate and the fashion they're supposed to, which leads people to develop constipation. Additionally, even if they aren't exerting their full effect, diarrhea by itself is a side effect of baclofen. And so I think it is important to look hard at medications, particularly those that are prescribed for symptom management when it comes to thinking about managing other symptoms in MS. It all ends up being interrelated. Next on this list, you'll see neuropathic agents like gabapentin. And the way that this can contribute to bowel incontinence is similarly to the muscle relaxants, where because of the way that gabapentin works, it slows down the signals from nerve to nerve, and finally from nerve to muscle. And so if the nerves are not telling the muscles to move or to contract or to push, then bowel doesn't move through too, often leading to constipation. Certain antidepressants frequently have diarrhea, nausea, vomiting, and GI effects just by nature of how they are metabolized and how they are absorbed in the bowels. And that's important to take a hard look at as well. And then finally, on the right side of the page, we've got some other causes that can end up interrelated to constipation. For example, often our treatments for overactive bladder, which is a very frequent symptom of patients who are living with MS, target the overactive bladder by drying things out. I think that's the simplest way to put it. There's a couple ways to do that. Sometimes the medications help the urine be put out more, so more frequent urine or diuresis. And then the second way is by causing something called anticholinergic effect, which means that folks are dried out. They aren't as moist in their mucous membranes in their mouth or their gut and GI lining. And that can lead to some side effects, including cavities when those moist mucous membranes are no longer quite as wet. And in the bladder, well, that's sort of what we do it for. We dry things out and then there's less urine on board. And then finally in the bowel, if there's not as much hydration ending up in the GI system, then that can cause constipation as well. Often, we miss asking about some of the GI irritants that can exist in our lives. And the two most common ones are the ones I've listed here, which are caffeine and alcohol. But not to be missed on this list are processed sugars, sugar-free candies and gums that often use things like xylitol or sorbitol. What these agents do, these GI irritants, is they go into your gut, and within your GI tract, they sort of pull more water into the space of the bowels themselves. And as a result, you can get watery stools. Caffeine and alcohol are common culprits, but I'll often start asking about supplements and even fillers in supplements or sugar-free candies. And I have had some surprise conversations over the years where I've had folks sit with me in clinic and say, "Oh, but I thought I was doing such a good thing by treating my sweet tooth with my sugar-free candies." And often that was the culprit for the fecal incontinence that they were discussing with me that day. And none of these medications would really have a role without really mentioning the disease-modifying therapies we use for multiple sclerosis. You see several names on here, including fingolimod or the S1P inhibitors, teriflunomide or Aubagio is the brand name for that, and the fumarates like Tecfidera or Vumerity or Bafiertam, and ocrelizumab, which is Ocrevus. And I'll go through kind of top to bottom. The oral agents can cause nausea, vomiting, GI symptoms, and I think that's a frequent item on the potential side effects lists of oral medications because those medications, by definition, have to get put into the gut, absorbed there, and that too can cause local irritation. So if you hear about reflux, nausea, or diarrhea, it's a direct effect of having those pills be broken down. And it's a frequent thing that we have to ask for when it comes to conversations about diarrhea or fecal incontinence, because it may be that the side effects don't warrant the medication. And those are some hard but important conversations to have with your MS specialty team. The other thing I added to this list is ocrelizumab, and this is rare, but I think it's worth mentioning that in the last couple years, we have discovered that about 1 to 2% of patients who are treated with ocrelizumab develop something called inflammatory colitis. What that means is that there's inflammation on the lining of the gut, and that colitis, because it changes the lining of the gut, it makes it swollen and then affects the muscles from pushing and contracting, folks often get diarrhea as a result of that. In fact, because of the degree of inflammation and the swelling in the lining of the gut, people can even get hemorrhagic colitis or bloody stools. And if that happens on this medication, it is absolutely worth bringing up with any one of your provider teams. Next slide. So then the question becomes, well, what do I do? If I'm having incontinence, who should I see about it? And I think there's several places to start. Of course, I didn't put on here. You should definitely chat with your MS specialty team first to say, are you having it? So that a really thoughtful conversation and look can be had at your medication list, at your diet, and at potential supplements, sugar-free candies. But if as that all has been exhausted and there's a thought that perhaps this incontinence is coming from weakness or sensory loss or symptoms from MS that don't have clear treatments, then I've listed a few resources on this page of where to turn to look for more answers. The first would be a registered dietitian. This is an expert in managing the dietary needs of an individual's body. And so what I love about the dietitians I've worked with here is that they are very good about listening and tailoring their recommendations to the dietary needs of individual people. And what they can do first and foremost is educate people. When you sit down with a dietitian, they will most likely do a food intake diary to get a sense of what exactly is going into your body, and then when is the incontinence happening, to try to set up and look for patterns that may be happening related to certain foods. They'll also provide significant education on where are the elements that could be changed in the diet to help address incontinence. And of course, Jeffrey will chat a little bit about that. And they'll also work with you in looking at your food diary on what that right balance of fiber may be, because there is a little bit of a seesaw effect where you can have too much or too little and end up in trouble. The next step after seeing a registered dietitian would be seeing a GI specialist or a gastroenterologist. And they are often the folks I turn to when there is direct intervention needed. These are often folks in the medical field, they are clinical providers, And they can think about additional prescription therapeutics that can help slow down gut motility or speed it up if there's constipation causing it. And so there are prescription agents that may be considered once we've tried management in behavioral and lifestyle measures, you've had a chat with a registered dietitian. The other consideration here is that sometimes for symptom management, it is important to chat with urology to ensure that the treatment for one isn't getting in the way of the treatment of the other. I had mentioned earlier, sometimes overactive bladder treatments beget constipation, and that may cause fecal incontinence. And so it is important to have that conversation if overactive bladder is also a symptom someone is feeling, to say, are there alternate options that may allow us relief without ending up causing constipation or fecal incontinence? And I think I've got GI on there twice, so we can go to the next slide. So with that, I'll end with our polling question for today. And what you'll see here is an inquiry as to which of the following can be helpful in addressing bowel incontinence. I've written down here flaxseed, daily activity, fruits and vegetables, drinking water, or all of the above. And I hope that this will help us lead right into Jeffrey's discussion. But the answer here is E. Each of these things, just like that seesaw effect I mentioned when it comes to fiber, has a role in contributing to the health and the motility of your gut. And so flaxseed, daily activity, fruits and vegetables, and drinking water may all have a role in addressing bowel incontinence. So with that, I'll turn it over to Jeffrey to take on the next part of today's talk.
Thanks, Suma, and what a great presentation to talk about bowel incontinence. And just a reminder to the participants that we're really focusing on bowel movements today as opposed to bladder, but we're happy to answer questions that come up in the Q&A section later. So excuse me, I'm a little under the weather, so I'm wearing the mask. We're talking about management of bowel dysfunction. In other words, neurogenic bowel dysfunction is another term that we constantly use. We may also use interchangeably constipation or fecal incontinence on our notes. So if you see those words, just know that that's what we're referring to, the abnormal function of our bowels. Constipation is typically about 3 or less bowels a week. And so one of the first things that we usually ask our patients is, what is normal for you if you're complaining about constipation that day? So what is your normal regimen? Is it every other day? And has it been every other day for many, many years since you were an adolescent or since you were a child? Or is that something different that happened after a relapse or from your diagnosis? And has it gotten worse? Those are some ways that we can help differentiate what is normal versus abnormal. And there are different types of bowel dysfunction when it comes to constipation, where there's a primary constipation, again, that this is possibly related to other lack of motility in the colon or the transit, versus MS, as Suma mentioned earlier, related to lesions from the multiple sclerosis and the spinal cord involvement and meds that could cause them because of the anticholinergic effects. She listed a lot of the very high target meds that we commonly use in management of MS, including TCAs, which are typically tricyclic antidepressants that have those anticholinergic effects, as well as the ones for bladder dysfunction. And there are many other things that can cause it, but I'm just naming a few. And we'll move on to the next slide. So more of a holistic approach. Most of the patients, most of the people that come in to see us, they want to know, like, what can I do myself to help manage constipation? And so one of the most cost-effective and easiest things to implement is, first, we review the meds, as Suma mentioned. We look at all the medical history. We look at all the medications that you're taking, if you're taking any, and we try to identify which ones are the ones that may be contributing to the constipation. And if we can adjust them, we will adjust them or recommend adjusting them. But that may not always be the case. So then we move forward to making sure that we remind you to stay well hydrated, which is typically a problem in the MS community. Staying well hydrated is a challenge for most because they're concerned about the bladder dysfunction as well. So like if they drink more water, do they need to be more cognizant of the bathroom nearby? Are they going to have an accident? May they have a leakage? Maybe they're driving, an hour to see you and they don't want to have an accident on the way. And therefore they limit the consumption, or you limit the consumption of water prior to, or even perhaps throughout the day, so that you don't have an accident if you're going to work. So making sure that you hydrate well throughout the day. Typically it's half of your body weight in ounces. So it's averages out to about 8 cups of water a day of 8 ounces. High fiber, so you can't do one without the other. If you're going to increase the fiber, you have to increase your consumption of water. And they go hand in hand. If you don't hydrate well and you just consume a lot of fiber, you will still remain constipated. You're not going to have easily passed bowels. And some of the foods that may help you are like the basics apple. I've heard some patients actually tell me that when they eat the apple with the skin, it actually makes them go to the bathroom. Pears, broccoli, carrots, black beans. Now, I know some of this may actually increase gas, so keep that in mind. But these are some of the foods that may actually help with the bowel function. Bran flakes, whole wheat spaghetti, pumpkin seeds, almond, to name a few. I know some people like to drink hot water with lemon in the morning, and that helps them go to the bathroom. And then others, again, like foods that they know that will trigger them to use the restroom, like apples. Like Suma, I had a patient one time told me that they love chewing gum. And they would literally eat a whole pack of gum in a day, and that actually, because of the sugar inside the gum, it actually triggered them to go to the bathroom and have sort of like a watery, not necessarily watery, but like like an urgent bowel movement. Exercises, as she mentioned in the polling question, that we have about 600 plus participants and only 383 responded. So I'm assuming that the other ones were trying to respond but didn't get to the answer. But everyone should know that daily activities is really important. And it doesn't necessarily matter how much you do on a daily basis, as opposed to just being physically active. We know that there are possibly some limitations in the activities that you're able to do. But, there's a lot of stuff on YouTube now. And even with Can Do MS, there's a lot of videos that you can access these movement type of activities, and they're free. And so doing something on the chair, doing something on your bed is still pretty accessible and perhaps simple for you to do at home. But on average, the recommendation is 150 minutes a week. So if you can't do 150 minutes, which most people can't do in one shot, you divide it amongst the week. So you maybe want to do it 2 or 3 or 4 times a week, and you can start between 10 or 15 minutes at a time, whatever you can do, but as long as you're moving. And it doesn't mean that if you can't move your lower extremities, that you don't do any activity. Yes, you move your arms, you can move your torso if it's possible, and just do a lot of the movements that are available for you there. And if you don't know exactly what you can do, then this is a good time to speak to your provider and maybe consult a physical therapist and an occupational therapist if needed. Along that line, there is another option for this more of holistic approach, which is pelvic floor therapy. Pelvic floor therapy is often used for bladder dysfunction, where there is a storage problem. So we typically categorize bladder dysfunction between storage and emptying. And this is a way that it can help strengthen up the muscles of the pelvis. And pelvic floor therapy is often performed by a physical therapist that's trained. So there aren't too many out there, but if you look for one, you can probably find one and access them. It's a little more of a less conservative approach to learning how to manage your bowels, but it's a great option for those that want to approach a holistic management of their constipation. And then we'll go on to the next slide. So one of the more famous pictures, toileting schedule. We always talk about voiding schedule in bladder dysfunction, probably because it's one of the more common things that we talk about in the visits. But the same exists for bowel dysfunction. So we want to take advantage of our body's natural reflex that happens often when you eat your first meal or you drink your first cup of water, and it triggers that motility or that transit. And you want to take advantage of that opportunity to sit on the toilet in this position, as a picture posted there, if possible. And you can get a stool. You don't have to buy, there was one specific one that I know that they branded, but you can get anything. Just put them underneath your feet, put your feet up and sit in this position here. And it'll help facilitate the movement and the reflex so that you can actually try to go to the bathroom. So this sitting position is actually beneficial. Now, doesn't mean that you're going to sit here for hours, because then your legs will become numb and then you'll think you're having MS symptoms because you're compressing the nerves as you're sitting and you're sitting forward. So just making sure that, do this in a reasonable time frame. And if it doesn't work, you move on. But practicing this on a daily basis is going to be helpful. Just like we tell you when you void, you want to try to keep it on a consistent basis, on a consistent schedule, so that your body gets used to it and now you're able to sort of trigger your body to do the activity that you want it to do. Next slide. So some of the treatment options. So some of the pharmacological treatment options, we talked a lot about like the holistic approach, and are listed here. There are first traditional options, the second line options. We're talking about some tertiary options or third line options, which include transanal irrigation. It can also include percutaneous PTNS, percutaneous nerve stimulation. And then ultimately, if really required, which we typically don't resort to this, but if the GI specialist believes that this is a very important part of your management, then potentially a surgical intervention. Next slide. So I'm not going to go over all the words on the slides. I just wanted to put it out there for you guys so that you guys can look at them. But typically when we're talking about constipation, we typically go to osmotic laxatives first. And that commonly is Miralax, but there are other options. But there are also other options, including magnesium citrate, which is something that most people may consider using. Lactulose, I personally have not used it often. I typically use Miralax or magnesium as options. And then the next slide, we have a few other options here. So stimulant laxatives can be used with or just alone. So you can use the osmotic laxative and a stimulant laxative, or just a stimulant laxative after the osmotic laxative hasn't worked for you. And one of the common ones that most people may use is Senna or Dulcolax. Those are two of the options. And some of the other medications that are listed here are options, but probably not the go-to treatment options that we would typically use. Maybe one that stands out is Linzess, because it's often advertised for chronic constipation and IBS. And I know you guys talked about a little bit with Suma about constipation and fecal incontinence. IBS is another condition that may coexist or may be seen often in MS. And so this medication does come up quite often, but there are a few others. We typically reserve the prescription of these medications usually to GI, unless we feel really comfortable prescribing them, because you require a workup. Okay, the next slide. So we talked about constipation, and now we're going to talk about fecal incontinence. As someone mentioned, fecal incontinence is that involuntary movement or that function that exists because of in this situation, because of MS or perhaps some of the medications. And as she mentioned as well, excessive caffeine, alcohol, and then we talked about some of the sugars that are in foods, and some of the ingredients that can cause the stools to be loose and lead to fecal incontinence. And fecal incontinence, I think when I picture fecal incontinence, or when I used to picture fecal incontinence, I used to think a whole bowel movement, but it could also be leakage. So if you have leakage, that is part of this process, unfortunately. So you do want to mention it and not keep quiet when you see your providers, whether it's your primary care provider or your MS care team. So typically, when you have fecal incontinence, you want to bulk up what you have. So you'll use possibly Metamucil, which is a bulking laxative, which typically contains fiber. And then you'll add that with a lot of consumption of water. You can potentially use loperamide as another option. And then a lot of the GI providers nowadays are starting to prescribe or recommend a little bit more often biofeedback together with pelvic floor therapy, in which the person might help retrain their body to identify the muscle movements and help with the exercise of the sphincter, as she mentioned, that involuntary spasm that you may experience, or that involuntary movement of the sphincter that controls opening and closing, which may lead to the incontinence to be retrained, essentially. And then we have a few more options on the next slide, possibly two more. So we're talking about percutaneous tibial nerve stimulation. This is often used, I mean, when I've seen it, and probably some have seen it as well, we've seen it a lot in bladder dysfunction and overactive bladder. This is a very common now go-to treatment option once you've tried and or failed oral treatment options. But they have studied this in fecal incontinence specifically. A few studies have done so in constipation as well, but most of the studies have been in fecal incontinence. And it has been shown to have some improvement. It's not 100% improvement in the people that have tried it. They haven't had any negative consequences because of the PTNS treatment. However, they had some improvement, and then about 50% of those patients that had the treatment had responded to the therapy, meaning that they either had a resolution of their constipation or a significant improvement in their fecal incontinence. So it is something that may help. It's a little electrode, a little needle that gets poked into your leg, and then there's an electrode attached on the same leg, and it shoots electrical stimulation. The electrical stimulation is to help stimulate the sacral nerves, which strengthen the floor muscles and the sphincter. That's the idea behind therapy. And in overactive bladder, they often do this very frequently. So it's not that you'll just go one time, you get one treatment and you're done. It's pretty consistent for a certain period of time. They typically tell you how often you need to go, maybe once or twice or 3 times a week. Typically once a week to start for a certain amount of weeks, and then you see if you have some improvement or not. And then the next slide. The next treatment option, which is probably not a very common one right now, it's sacral nerve stimulation or neuromodulation. We again see this often in bladder dysfunction in MS. We're using it more and more for people that fail conservative treatment, meaning that they've tried everything else that they could have, including for bladder dysfunction Botox. And as a result, they have very minimal options left. This could be one of them where they'll do a trial of an implant. You'll test it out. It's essentially similar to the PTNS. It delivers a electrical stimulation to the sacral nerve through this implantable device, and it provides the electrical charge to the area that results in that altered sensation, and hopefully blocks the involuntary void that occurs. And this particular device, there's a few particular devices for sacral nerve stimulation, a few versions. But this particular device is called IntraStem, and this has been approved for fecal incontinence. So in very rare cases where someone has fecal incontinence that has not been well controlled with the conservative treatment, this may be an option. And as Suma mentioned earlier, you may have both bladder and bowel dysfunction. Bowel dysfunction can make bladder dysfunction worse. Vice versa, the meds that we use for bladder dysfunction may make bowel dysfunction worse. So in these cases where you have a little bit more of a complex situation, perhaps a sacral nerve stimulation might be a way to go. And typically the urologists do a very good job about explaining the options to patients because they understand the association there. And so they may offer you to trial it for a day or so, where they do a temporary install of the device and you see how you function at a very minimal voltage, a very minimal dose of the treatment. And then you can always alter it as time goes on if you really do proceed with the procedure. And in the future, excuse me, you guys. And in the future, if you need to, it can be removed. So this is not a for life situation, but it is an invasive procedure where they're implanting this device. And I think that really sums up the presentation on bowel dysfunction.
Awesome. Thank you both for all that information. Now we have plenty of time to get in to answer some of these questions. So thanks for questions. Throughout this time, go ahead and continue to put more questions in the Q&A box so we can answer as many as possible. So Suma, I'm going to start with a question for you. Somebody asked about the meds that you had listed and some of the treatments. Would those cause intermittent issues with bowel movements? Or if you're kind of consistently taking the medication, is that going to affect you all the time?
Yeah, it would be expected to be more consistent. And so if there are intermittent issues, I'll sort of use that question to launch me into another question I saw, which is you would want to think about other causes of intermittent GI trouble, such as irritable bowel syndrome. And so there's a couple of questions we got in the chat. One of them was, do any of these medications cause IBS? And I do think it's important to recognize that IBS, irritable bowel syndrome, has two types. That's IBS-C and IBS-D. C stands for constipation, D stands for diarrhea. And both of these conditions are thought to be what is a functional GI disorder. What that means is that there is a connection between what may be going on in the subconscious, stressors on the bodies, and having a chronic illness and a change in the programming of the gut. And you can probably hear it in the words that I'm seeing, but there's a little lack of understanding of exactly what drives it. But what we do know is it's kind of like uh, goosebumps when you're scared. It's this programming that happens. It's not like you're telling your skin to get goosebumps, but it's this similar tapping into wiring that exists to change what your body is doing in that moment. And so I think it's important to recognize some of the mental health and mood contributions, just like goosebumps when you're scared. Fear is an emotion that causes goosebumps. You can have stress, anxiety, depression as emotions that contribute to your bowel and bladder health. And so, one thing we haven't mentioned yet is just the importance of mental health check ins as part of chronic illness management. And that looks different for everybody. But in short, there's not any one medication that causes IBS of any subtype, but it is important to recognize that it might coexist with all of these things that we talked about when it comes to meds and disease modifying therapies that might be contributors.
Great, thank you. I have another question for Jeffrey. We were talking about things that you can add into your diet. How do you feel about probiotics? Is that something good to add in?
I mean, I use probiotics maybe once or twice a week. I don't go crazy and take it every day, um, but I do use it. Gut microbiome is something that's looked into more and more often now these days in MS, and we think that there is a connection, or the scientists believe that there's a connection between the gut and the brain. So doesn't mean that you're going to go out and spend a bunch of money on probiotics, but if that's something that is of interest to you, if you want to start taking it, you can always talk to your provider and see what they would recommend, because again, this is a relationship that you have with your provider. You don't want to necessarily do extra, but it is something that people do take. So it's not necessarily contraindicated.
Great, thank you. And this can be for either of you. We have quite a few questions related to suppositories. So first, are they recommended to help, excuse me, evacuate the bladder? Are there side effects to suppositories? And if you start using them, are you hooked on them, or can you flow in and out of using them?
I'll take this one. I'll give you a break, Jeffrey, which is that you don't get used to them because it's a direct irritant. So taking a glycerin suppository, for example, it's kind of covering that area with that thick glycerin, sugary, syrupy compound. And what that does is it irritates the lining and it causes the gut to push. And so to answer that question in short, there are so many kinds. They can absolutely have a role. And what I'm hearing in this question, though, is that some people do become reliant on these suppositories because of the dysfunction in their bowels. And because of that, it's not that they're addicted or they lose efficacy. It's that until that local direct irritation is caused by water or glycerin or what have you, a person's body doesn't get that stimulus to push from inside.
Yeah. Yeah, it's just there are studies that show that it is very effective when used. And one, I think the bisacodyl is probably more effective than the glycerin suppository. But it's something that can be used as well. Yep.
Great, thank you.
I did
Again,
see a question that I wanted to answer up very early on. It says I can't find it now, but I think the question was, does everyone with MS develop bowel and bladder dysfunction? And the answer could be no. It doesn't mean that everyone will have one or the other or both. But as time goes on, especially when we think that perhaps not so much now as it was before, but because people are well controlled, but as you have relapses and you continue to accumulate more lesions, the risk to go up because the lesions may land in the spinal cord, which can contribute to this dysfunction. So there is a chance that you may at some point experience bladder or bowel dysfunction or both, but the numbers really vary. I remember reading the papers. It said anywhere between 30 to 70% of the patients may experience one or the other. So it's not 100% for everyone, especially for those that have limited lesion load or locality to the brain and not necessarily the spinal cord. So I hope that answers that question.
Thank you. And I know somebody asked, like, once you start having bowel or bladder issues, we're talking about some symptom management. It doesn't mean that you're always just going to have these problems until the rest of your life. Is that correct? You can manage.
It's possible. I mean, well, let's be realistic. We
Yeah.
want to be honest with everyone. It's possible that once you develop these symptoms, it may be lifetime. The only way to really know is to manage and see if it gets better or if it's manageable and improves. It also differentiates whether it's from MS or something else. So if you have an acute diarrhea for several days that you didn't have before and possibly associated with a viral illness or a fever, that's unrelated to MS, and that's something that can happen. And then that function will go back to normal or your normal. But
And
if it's related to MS, it may start off as mild. Typically, hopefully, we hope it stays mild and may not progress. But then in some cases, unfortunately, it may progress.
and that actually leads to another question that somebody had. Excuse me, let me find it here. Does it matter if they're having diarrhea, incontinence, what have you? Does it actually matter if that's stemming from MS or from something else going on? Or are the management strategies kind of the same? I know if they're trying to find a medication that's causing it, that might be from something else. But do the other management strategies change?
So, I mean, I would say medication-wise, so pharmacologically. So holistic approach or natural approach, it's the same. It doesn't necessarily make a significant difference. But when you start getting into the meds, perhaps some of them might be better off if it's neurologically related and versus some of the other. Like if you have a spinal cord injury or you have MS, you might necessarily benefit from a sacral nerve stimulation as opposed to a different type of etiology or cause of the dysfunction.
Yeah, I
I
think
don't know,
it's
Suma, what do you think?
no, that's what I was thinking. I think the options that we have are probably similar, but how we approach them and then what we sign people up for and recommend can vary depending on what we think it's coming from. So absolutely, I think it's helpful to differentiate the two and still do all of those kind of healthy eating and staying active things as much as one can within your functional limits.
Is it helpful to take any medication, whether it's MS related or not, and bring it to your neurologist or your nurse practitioner to be able to see the larger picture if you are having these issues to help diagnose?
Oh yeah, I see Jeffrey
Always.
nodding too. Yes,
Yeah.
gosh, I think I practice in several clinics, but one of my clinics requires folks to bring their meds with them, and that's often really eye-opening to me as a provider is to get a sense of what all is going into this person's body and then which one of these then could be contributing. So I think absolutely is the answer to that.
Mm-hmm. I completely agree with Suma. It's best if you especially when you have issues remembering things, if you don't have a picture of them, bring the bottles with you and we'll be happy to look at them. But it should be done.
Awesome, thank you. We actually had a question early on. Somebody else marketed it as a marker sensation. So when someone's wiping, they're wiping, and constantly having something come on to their toilet paper. What does that mean? How can they help ease that stress while going to the bathroom?
I have not personally heard of that. This is the first time I read it. Um, what I remember reading in the chat, because a lot of people are very active in the chat. Um, that could potentially mean that either you have some leakage when you're using the restroom, perhaps. I mean, that's the only thing I can assume since we're not able to chat with the persons on audio. But just from reading, I'm not sure what else to make of it. I haven't heard of that description before of a marker. So the only thing I could think of is that it has to deal with the lack of voluntary contraction of the sphincter, and therefore leads to some incontinence that unfortunately you're not able to completely empty your bladder, or you completely empty your bladder and there's still some leakage happening and you're wiping and you still have evidence of feces.
So I have heard that before. It's definitely something I've run into a fair amount. It's often because of constipation and incomplete emptying, where there is a piece of stool sitting there. And so then you're wiping and you're wiping and you're just catching the tip of the marker, the tip of the piece of stool
Okay, I
every
get
time.
it now.
Exactly.
That's an
And
interesting
someone else
reference.
actually mentioned in the chat or in the questions, actually, like a golf ball sensation. Same thing. It's this incomplete emptying, and I would use that as a sign to think about enemas, to think about suppositories, and to think about manual disimpaction, which is something that we haven't really gone into there too. But sometimes that can help relieve that marker sitting there. And with manual disimpaction, I'm not recommending anyone go sticking fingers in their rectum, but it is important to talk through that with your provider team, because there are folks that can help with that, and that can provide significant relief. I've had people end up in the emergency department not knowing what was coming out of their bottom, and once that was relieved, their bowels were stimulated and they were able to go again regularly.
Great, thank you for that answer.
There's something new today about the marker.
There's always something new, right?
Absolutely.
That's why we're all here.
Yeah.
Thank you, you guys.
Exactly. So we've had a lot of people comment about Botox. Some people commenting how it's helped their bladder function, but a lot of questions on whether Botox can help with bowel function as well. Can you speak to both sides of things, since a lot of people do have that question about bladder as well?
Yeah, I mean, we often use both. We often refer to urologists to use Botox for bladder dysfunction. I personally, again, haven't heard of Botox being used for bowel dysfunction. We typically, I don't even know how that necessarily would work as far as they're possibly. I'm not even going to get into that, but essentially the resources that we gave you today are the go-to treatment options for bowel dysfunction, including the sacral nerve stimulation, the percutaneous nerve stimulation, tibial nerve stimulation. As Suma mentioned, the digital stimulation, the suppositories are options as well. So there are an abundance of options that possibly we may not necessarily always access because we're not aware of them. But now that you do know, those could be topics of conversation that you bring back to your providers.
Great, thank you. I do want to just point out, somebody in the chat wrote, aim for progression versus perfection. And I really like that, and I think that that really goes along the path of can-do MS in general, is little bits at a time. If you can help even a little bit, it does help your daily struggle. Just wanted to point that out. All right, so there's some folks that are asking about just a little bit more information about not having that sensation that you talked about, Suma. Not having any sensation before they're ready to have a bowel movement. And this has also come into play when people need help transferring to a toilet. Can you talk a little more about just when people come to you with this problem, what's like the main thing that you kind of go to help them relieve that even just a little bit?
Yeah, that's a tough conversation to have. It's one that I honestly tell folks, we don't have meds that can put sensation back, right? We have meds that if there's nerve pain and tingling and burning, we can turn it down, but we can't give back sensation. So where that really comes down to is, how do we compensate and how do we keep ourselves from getting to that point? And so one of the best behavioral techniques that I've found just in recommendations is timed voiding and ensuring that you're keeping a really regular routine. Because at that point, you're not reliant upon the sensation that isn't there, but it's really about ensuring that with this diet and this amount of movement and these medications to help, this is when I would expect myself to go, so that you're not waiting until that last minute when the sensation is urgent.
Great, good
It's a great
tips.
strategy, the toileting strategy.
Absolutely.
I did see a question there. It talked about Kegel classes and working on it in the Q&A section. That might be a good time to bring up pelvic options of pelvic floor therapy and maybe a urogynecology consult if that is an issue in the Q&A, and that was one of the questions. And then the interstem we talked about already. That was an early question, but I hope I was able to answer that during the presentation, that it may provide dual benefits for the bladder and bowel dysfunction. And there is an option to trial it. So you can try it without having a full device implanted and then take it out when the trial is done and see if you notice the difference. So those are two of the questions in the Q&A that we thought that we were able to answer during the presentation.
Yeah, I also wanted to point out, I did put a link to a podcast for a pelvic floor specialist. So we didn't touch on it a ton today, but there is a link to that if you want to hear more specifically from that type of a specialist. A couple other questions that we had. Can my bowel incontinence affect how often I get UTIs?
Absolutely.
Yeah.
I don't know, Jeffrey. I mean, there's so many ways, but directly, right? I think just having incontinence, once you've had fecal incontinence, there's no time that's too quick. You've got bacteria that's not where it's supposed to be. And those spots, your bottom and your front, are so close together, right? Those holes are so close together that the bacteria can move quickly. And so absolutely. And in controlling that can help.
Yeah, I like how you described that, because when we think about anatomically where they're located, in women you have a short distance there, and so leakage can easily pass, the bacteria migrate and lead to this infection, unfortunately. So it's something that you should take care of as soon as you feel it, if possible, but do know that that can increase it.
Thank you.
I'd like to take a moment to just comment on pelvic PT, if that's okay, Paige. I think there were some questions earlier about what exactly it entails, and I do think it's important to not alienate our patients who may affiliate with the male gender. And the reason I say that is, in our head, sometimes Kegels always come up as pelvic floor physical therapy. We recommend it, or we try to, frequently after folks have children, after that abdominal stretching. But one of the things that was really eye-opening to me is just how much core activation and exercising and lower back muscle strengthening goes into pelvic floor PT. So it's not just private parts of women that we're talking about when it comes to pelvic floor PT, and it really is to try to create that kind of feedback system of what's the movement and what's the sensation and how do I use that to help myself push. They do a phenomenal job.
And men, we can participate in pelvic floor therapy as well. We do for different reasons, but yes, we can participate in pelvic floor therapy.
I think that's a super important note. And because you kind of brought up some specific exercises, Suma, I do want to circle back around to Jeffrey's point of movement and exercising a few times a week as well. Are there certain things like strength training, cardio? Does it matter what type of movement you're doing? Does it matter for constipation versus incontinence, loose stool, all of these things? Or is movement and it's good?
So we would like to say ideally movement is movement, which is good. So any movement at all we want. But if you can perform some type of cardio training, not necessarily strength training per se, but Zumba, some walking, maybe on the bike, things like that, that will help get your body moving, your heart rate up. Those are the ideal type of exercises, but obviously incontinence might be difficult to do some type of aquatic therapy, just because you may have an accident. But otherwise, these exercises that you do is whatever you find is comfortable for you, and whatever you feel is going to work for you. Definitely avoiding excessive heat exposure, avoid overdoing it. So don't go running outdoors in this heat this summer, because it's been very hot. That can exacerbate some of your MS symptoms. But otherwise, exercise is overall recommended at any point in time, at any interval.
Great.
And I do see really quick MRI and neuromodulation. So the sacral nerve modulators or the neuromodulation devices typically are MRI safe, so compatible. So you can look at their website and you can have that discussion with the urologist and even the manufacturer who makes it to verify, and they'll give you a card that you would take for your MRI appointments, and it'll turn off and you'll have to get it turned back on typically.
Very good point. I'm going to drop this in the chat because somebody had it in the question and answer box. I spelled society wrong, so I apologize. But the National MS Society actually does have a tool, Find Doctors and Resources. So if you don't have a urologist or a specialist, if you can't get into your neurologist to get any recommendations, you can use this tool to help find people in your area. But also go into your normal care team and ask if a specialist would help you, and ask for recommendations from them as well. I'm sure that Jeffrey and Suma have given many references out to specialists.
Yeah, we have the honor and the pleasure of having urogynecologists and neurourologists. So these are urologists that are specially trained and do an extra track in neurology, and then we have urogynecology as well. So we have access to both, thankfully, and it's been really great for our patients. But I know that sometimes, depending on the region where you're located, it might be difficult to access. So.
Absolutely. Awesome. So we are getting towards the end here. So I do just have a few more slides to go over. As always, we want to encourage everyone to connect with us on our social media pages for the latest programs, resources, and MS news. You can also register for our monthly e-news email series. You can visit our website and you can find the e-news link on there. Once again, I would like to thank our generous sponsors for supporting this year's webinar series. Thank you to our sponsors. One final thank you to our speakers, Jeffrey, Suma. The information shared here today was invaluable. Thank you so much for joining us.
Thank you, guys. You guys were
Thanks for
great.
having
A lot of
Yeah.
questions.
Absolutely. And to everyone who took time out of their evenings to join us for this webinar, we want to thank you and we hope to see you next time. Have a great evening, everyone.